Thank you for inviting me to make this presentation. We have been collaborating with Danish team for many years, for more than 10 years, and referring patients with severe congenital hyperinsulinism to additional diagnostic and treatment. And there is a classification of known causes of hyperinsulinism, which include persistent and transient forms that also can be syndromic and non-syndromic. And you can see different causes, genetic causes of the disease with different treatment and different management. We have conducted a 10-year national study on the incidence of hyperinsulinism in Ukraine, and our figures are lower than the incidence of hyperinsulinism in other European countries and Japan. And the distribution, you can see here the distribution of hyperinsulinism in Ukraine according to genetic etiology. And in case of persistent form, we could solve almost 80% of cases, whereas in case of early remission or transient form, we can solve only 44% of cases. And if we analyze the situation more deeply, there was a much greater genetic diversity in case of transient hyperinsulinism compared to the persistent form, where only mutation of potassium channels were identified. And medical if I analyze take-home messages from genetics, so genetic diagnosis was confirmed in 67% of patients in our cohort, with the highest pickup rate observed among those with persistent form, and pathogenic variants in potassium channel genes were the only identified genetic causes of persistent form, with the greater genetic heterogeneity observed in those with early remission form. And if we're talking about medical management of hyperinsulinism in Ukraine, it also has its own differences, because octreotide was the first line of continuous treatment since diazoxide is not easily accessible in Ukraine. And in 6 octreotide unresponsive patients, diazoxide was outsourced and given as a second-line treatment. And in 3 severe cases, glucocorticoids were also used additionally. And glucagon injections had routinely been given in case of severe hypoglycemia. The treatment regime was guided by drug availability, drug individuals with severe persistent form underwent PET-CT scanning, followed by surgical treatment in Denmark. And the median age of surgical treatment was 6 months, and the age of last follow-up was 6 years. So you can see here the genetic causes, histological forms, and treatment of 22 individuals with persistent non-syndromic hyperinsulinism, where the vast majority of patients had focal form of the disease, but 2 patients had diffuse form and 3 patients had atypical form. PET-CT is very important in the congenital hyperinsulinism visualization, and based on our previous research, Doppler PET-CT scan was excellent in predicting focal disease and superior compared to Galli PET-CT. It allows to differentiate focal and diffuse forms with a high sensitivity, specificity, and accuracy of 100%. Here, there are some examples how it looks like in case of focal form, for example, and how it looks in case of atypical form. And summarizing our imaging techniques, it's possible to say that Doppler PET-CT scan had fundamentally changed management strategies, particularly in patients with focal disease, with a very good sensitivity for detecting focal lesions and accuracy. And in our study, Doppler PET-CT predicted the histological type in all cases, including the 3 histologically atypical patients. If I talk about surgery, parents are always very worried about the consequences of surgical intervention. And of course, I must say that depending on the form of the disease, focal, diffuse, or typical, the consequences of the operation can be completely different. In case of focal form, we had transient fasting hypoglycemia and transient exocrine insufficiency and postoperative hernia. But the most important that we had complete hypoglycemia recovery in all patients with a focal lesion with normal postoperative fasting test. However, in case of two patients with diffuse form, one with the dominant de novo ABCC variant developed a relapse of the disease after 80% of pancreatic resection. This patient received treatment with a long-acting somatostatin analog, which prevented further severe hypoglycemia. However, in one case, 90% of pancreatic resection was curative. And the worst outcome was in case of atypical form because 2 or 3 individuals with a typical pancreatic disease had relapse of hyperinsulinism, and in one case we also had to initiate long-acting somatostatin analog and after the surgery, and it was stopped only 9 years later. But the second patient continued to take octreotide, diazoxide, and glucocorticoid following surgery, and we could stop glucocorticoid only 1 year post-surgery. And syndromic forms of hyperinsulinism have separate clinical features. Of course, parents are very unhappy when they are diagnosed with congenital hyperinsulinism, but I must say that if we're talking about syndromic hyperinsulinism, some of the syndromic forms probably can be even worse because they have more severe course of the disease. And perhaps not so much of hyperinsulinism itself, but because of other specific features and characteristic of syndromes that can be very serious. So you can see here different syndromes and different genetic etiology, and of course different clinical characteristic, different clinical course of the disease management and treatment. This is the case, is one of the cases you can put the diagnosis right at the door when the patient comes to your office. And I think all colleagues understand what I'm talking about now, because such a severe form of macroglycemia and hyperinsulinism immediately indicates what the disease the patient has. So she was born large, with a large birth weight, and macrocemia and macroglycemia and abdominal wall defects and kidney cyst and congenital heart defects, but with normal karyotype. She had hypoglycemia since birth, but with normalization of blood glucose after frequent feeding and glucose uptake perils. And we made genetic testing just to be sure, and we confirmed Beckwith-Wiedemann syndrome. And why, despite the absolute clarity of the diagnosis, it's still necessary to make genetic testing because you can see a lot of different clinical symptoms, and the most important, different cancer occurrence in case of different forms of the disease. And we had this awareness about cancer occurrence, and it's possible always to check this situation. And this patient undergone 4 operations for severe macroglycemia in Ukraine very successfully. But since we have this awareness about cancer occurrence, one day our oncologist told us that where the syndrome was diagnosed clinically almost immediately. But there was still a need for genetic testing to be absolutely certain. This patient was 1 month and was also affected with anemia, and at presentation he received a very high insulin dose, and insulin treatment was stopped after 3 weeks following compliance of fasting hypoglycemia and subsequently whole day hypoglycemias. And hypoglycemic episodes with the lowest blood glucose about 1 millimole per liter had no clinical symptoms and were compensated with a diet and oral glucose. And this patient had very severe glucose fluctuation from 1 to 20, from 20 to 1, and parents always ask what to do. Should we start insulin? Should we start octreotide? But they were eventually very well controlled by correction of feeding only. And we made genetic testing and confirmed Donahue syndrome, where the one of variants was confirmed to be maternally inherited, but another variant was not detected in the parents' leukocyte DNA. And since non-paternity was excluded, it's likely that another variant had arisen de novo. So it's a very unfortunate case. And unfortunately, this patient died because due to systemic multiple organ failure, as it was described everywhere for all patients with Donahue syndrome. And our second patient with Donahue syndrome also died. And she was a girl with a very big ovarian cyst and with intestinal compression, and she required even ovariectomy because of this. And unfortunately, the second patient with Donahue syndrome also died. So summarizing our syndromic cases, I have to say the syndromic cases were quite rare forms of congenital hyperinsulinism, but all their transient and did require PET-CT and surgical treatment. And in conclusion, a genetic diagnosis was achieved for 67% of patients in Ukraine with a higher pickup rate observed in those with persistent form. And within the Ukrainian population, potassium channel variants were the most common, accounting for all genetic diagnoses of persistent and non-syndromic early remission form. The genetic and imaging studies enable subtype targeted treatment with surgical cure achieved in all individuals with focal disease. And I also would like to emphasize the importance of a multidisciplinary team to improve treatment outcomes. This implementation of rapid international collaboration between teams of geneticists, radiologists, surgeons, endocrinologists, histologists has improved disease management in patients with persistent form, especially in those with focal form, with predicted better neurological outcomes, less financial and psychological burden on family members, due complete cure of the disease or alleviation of its symptoms. And our acknowledgements are we are very grateful for genetic testing. So Sarah Flanagan from the UK and Congenital Hyperinsulinism International Organization, who founded genetic testing in Exeter. We have genetic testing in Ukraine, but unfortunately it's not very cheap. And it's very good to have this possibility to make free genetic testing for such severe cases of hyperinsulinism. Also very grateful for surgery to Hans Christian Andersen Children's Hospital and Odense University Hospital in Denmark, and also to Danish Ministry of Health for free hospitalization and surgical treatment of our children with persistent form of the disease after the Russian aggression. And we also referred one patient to Germany, so we're very grateful to German team. And thanks to Olga Volgova, who helped us from Charitable Foundation, who helped us raise money for treatment in Denmark before Russian aggression. And at the very end, this is the Russian strike that was carried out on the largest children's hospital in Kiev in the summer of 2024. And I must say that I worked in this hospital for many years. Moreover, I was a patient of this hospital and was treated there when I was small. And the Russian missile completely destroyed the department, one of the department to the ground. And you can see children with cancer who had to continue their treatment, their continuous infusion in the open air after the strike. And it looks like an endless barbarism and atrocity. And we are very grateful to all countries, including European countries, especially Denmark, who always helped us. And we will be very grateful for this, and we will always remember your help. Thank you for standing with us, and thank you for your attention.